Hello. In my first talk in this series, I looked at how the underlying principle of medicine, that of making a diagnosis on which to base rational treatment, is often ignored. I illustrated how the medical establishment is complicit in this process. In the second talk, I explored why this might happen. Today, I'm going to further explore how ignoring the fundamental principle of making a diagnosis creates and supports a whole industry. I will show how this industry has evolved and is perpetuated with the encouragement of government, its agencies, the scientific press, and others. The fundamental principle of medicine is very simple. The patient has a symptom, which is commonly pain, and most of us suffer transient or episodic pains of one sort or another throughout our lives. Most of these episodes will get better whatever we do, and it doesn't really matter if we don't know what the cause is. A consequence of most pain improving of its own accord is that whatever treatment we use, it will appear to have been effective. However, if you have a persistent, disabling, or progressive problem, and you want to consider rational intervention, you require a diagnosis. And I suggest that if you are ever recommended treatment by anyone, you should ask what the diagnosis is, what is the rationale for the proposed intervention, what are the risks, and is there any evidence of efficacy. It being acceptable, even encouraged, to treat the symptom of back pain without a diagnosis has led to an edifice of interventions, publications, guidance, and tick box exercises built without foundation. It is like a house of cards. And as it turns out, the historical context of this phrase is interesting and pertinent. On my left is John Milton, a 17th century English poet, famous for writing Paradise Lost, which has been the subject of and inspiration for vast amounts of art and other literature. He was a supporter of the English Revolution, which had two main targets: the monarchy and the church. The first record I can find of the phrase House of Cards is found on page 54 of a lesser-known publication of Milton's, of Reformation touching church discipline in England and the causes that hitherto have hindered it. The established church, he says, want but one puff of the king's to blow them down like a pasteboard house built of cork cards. He, in common with all revolutionaries, considered the church hierarchy to be extremely expensive and to contribute nothing to the spiritual well-being of the people. Not dissimilar to my arguments regarding the current medical establishment, as we shall see. There are other similarities between what the revolutionaries were objecting to and the current behaviour of the medical establishment. An example of how structures are built around the non-diagnosis of non-specific low back pain is this paper published in The Lancet in 2011. It compared something called stratified care with current best practice. It concluded that the approach would have important implications for future management of back pain. The authors stated a one-size-fits-all primary care strategy, that is, all people with back pain receive the same treatment, is suboptimum because it ignores the differences between patients. It was the product of a Damascene moment. What amazing insight! They are suggesting here that there are different causes of back pain, and not everyone with the same symptom of low back pain should be treated the same. The authors have come dangerously close to rediscovering the 2,000-year-old Hippocratic principle of making a diagnosis. They were so close, but instead they described using what is called stratified care to treat people with the symptom of back pain. They proposed that everyone with the symptom of back pain fill in this simple questionnaire. The score is supposed to measure risk of poor prognosis, by which they mean risk of persistent disability because of back pain. The higher you score, the higher the risk of persistent disability, and the more physiotherapy and cognitive behavioural therapy you are allocated. This seems completely bizarre. Physiotherapy and cognitive behavioural therapy will not help a disc prolapse or an insufficiency fracture or spinal stenosis, no matter how much you do. At the other end of the spectrum, nor will it treat a significant mood disorder. In fact, it's not clear exactly what any combination of physiotherapy and CBT is supposed to treat. We all know that if something looks too good to be true, then it probably is. Panacea was the Greek goddess of universal remedy, and this is an 18th century woodcut of her in action by a physician, J. Gazzola, for his book, The World is Deceived by False Doctors. What is forgotten about Panacea is that she had a whole family of skilled siblings to call upon for help. These included a brother, King Tricker, who was skilled in diagnosis. And this is the essential requirement which is missing from the start-back methodology. The basic proposition underpinning start-back could make medicine based on diagnosis redundant. All pain could be treated at very little cost. We could all get treated by filling in a questionnaire online and be issued with a coupon for physiotherapy and cognitive behavioural therapy. It's simply too good to be true. People with cancer, which will not get better without intervention, could score very low, and people with disc prolapse, which could well resolve without intervention, could score very high. Not only is the fundamental proposition of this paper implausible, it contains several basic flaws. For example, the questionnaire they have created is claimed to measure something they call risk of persistent disability due to back pain. Measurement is important in science, and we need to measure variables with appropriate tools, in the same way we measure length with a ruler. It is not clear what persistent disability due to back pain is, let alone how it can be measured in a meaningful and reproducible way. What is the scale being used? Where is the beginning and end of the scale? What are the units? Is it linear? How reproducible is it? How does it relate to the established practice of basing prognosis on diagnosis? How did such a flawed paper get to be published by The Lancet, which refers to itself as setting extremely high standards? We select only the best research papers for their quality of work and the progression they bring. It appears that the Department of Health in the UK takes this statement at face value. Based on this single publication, it has now become policy that start-back questionnaire is filled in multiple times for people seeking help with their back pain. Here I have highlighted where it appears in the commissioning guidance to the NHS. In fact, targets are attached to this questionnaire being completed with financial penalties or rewards. So based on a single publication, we have a situation where everyone seeking help with the symptom of back pain has to fill in a questionnaire on multiple occasions. This process has to be administrated and recorded with absolutely no clear benefit to the patients. In the belief that the scientific community and scientific publications are all interested in seeking truth, my colleagues and I undertook a simple study to point out that the concept of symptom stratification, in the absence of a diagnosis, is misguided. You can read the full paper using the link shown. We hypothesized that for this approach to have any credibility at all, the score should reflect whether there was a structural lesion within the spine which was responsible for the patient's symptoms or not. We looked at people seen by one of our extended scope practitioners. They completed the Start Back questionnaire and had an MRI scan. The person's symptoms and signs were then discussed with a surgeon who had sight of the scan. People with a cause of pain identified by the scan and for whom surgery may be an option were offered an appointment with a surgeon. 1,042 sequential people were included, shown in purple. No surgical lesion was identified in 748, which was 72%, shown in green. A surgical target was identified in 294, which was 28%, shown in yellow. There were 336 people, shown in orange, with a high Start Back score. A high Start Back score was more frequent in people with a surgical lesion, 37%, shown in red, as opposed to 30%, shown in blue, of those with no surgical target. In other words, if you have a surgically treatable lesion, you are more likely to score high on the Start Back scale. If guidance had been adhered to, these people would not have had a scan, the structural lesion would not have been recognised, and they would have been offered high intensity cognitive behavioural therapy and physiotherapy. There is no evidence or even rationale for this to be effective, as acknowledged by the Start Back authors themselves. But they would have been denied surgery, which is extremely effective. The Lancet had published the paper on which subsequent national guidance had been based, and never shies from taking the moral high ground. Therefore, we thought it was appropriate to submit our findings and thoughts to the same journal. Our submission was rejected without review. We wrote an appeal, and after several months were invited to resubmit the paper. It was submitted late one weekday night and was rejected very early the next morning. It had clearly been given no consideration at all. We contacted the Lancet's ombudsman and received no reply. We wrote a further letter to the Lancet. We explained that it was hard for us to understand why they did not consider a debate on this subject important, particularly because they had published papers in support of the concept of treating people without a diagnosis, thus lending the notion credibility. We requested to know why our paper had not even been sent for review. This was the response. Of particular interest is the phrase, "We tend not to give specific reasons why we reach our decisions at this stage in the process, and there are, I believe, many good reasons for this." So, the medical publishing establishment promotes peer review of papers submitted for consideration of publication, but they decide which papers to send for review without divulging the criteria they use. They also decide who to send the paper to for review. This doesn't really seem to be consistent with a search for the truth. Might it be that there are vested interests at work? It doesn't take long to find expressions of concern regarding academic and medical publishing, and particularly concerning Elsevier, who own the Lancet. It may or may not come as a surprise that medical publishing is about profit, not about truth. There is little incentive for a journal to publish a paper which questions its credibility when its claim to credibility is responsible for its profit. Not only did the Lancet publish the Startback paper, but it has published and even commissioned other articles supporting the principle of treatment without diagnosis in people with back pain. At the same time, they might perceive that such a challenge to established practice across many fields might challenge their current popularity. The problem is not confined to Elsevier and the Lancet. The BMJ is no better, even though it is owned by the British Medical Association. Here, its editor, Fiona Godley, is decrying the ubiquity of vested interests in medicine, but fails to include her own publishing business.
Corruption of the scientific process, and it happens both through commercial interests, as I've said, drug companies, device companies, academic institutions unwilling to confront fraud in medical research, and individual academics who have their own agendas, their own careers, their own closely held, passionate beliefs, which do affect, and there's endless evidence to show this, do affect the outcome of that research. It's not my job to be popular. No, I'm very clear about that.
The government is particularly invested in the House of Cards in the UK via the NHS and its various quangos, of which there are a multitude. One of the most recent of these is called GIRFT, Getting It Right First Time. I received emails containing links to various idealised pathways of care. As is common in the NHS, the emails had passed through several layers of management via 2 separate routes before hitting me at the coalface. This particular pathway involves lumbar, medial branch blocks and facet joint injections. It is yet another example of making something which should be simple into something complicated. What I suggest is that the person with the problem see a person skilled in diagnosis, and the risks and benefits of the treatment options available are discussed, following which a decision can be made about how to proceed. It's actually a fairly simple process. Instead, we have this chart of largely meaningless advice. What is worse, in this particular instance, as mentioned in my first talk, these interventions are probably useless at best and damaging at worst. Here, the taxpayer has paid for the creation of an unnecessarily complicated document to advise on how a potentially mutilating treatment, which I don't believe any doctor would have done to themselves, can be accessed First time. A great achievement, for which I'm sure those involved will be claiming credit and reward. To add insult to injury, these pathways are adorned with the logo of the British Association of Spine Surgeons, of which I am a past president. BAS is an independent organisation which aims to maintain and improve care for people with spinal problems. I'm not sure how my professional organisation's logo came to be on a government document. The membership was certainly not consulted. A cynical person might be concerned that this is related to members of the BAS executive also being paid members of the NHS executive. This is a common scenario in medicine and represents another layer of vested interests. There are very few pathways by which the monopoly provider of healthcare in the UK, the NHS, can be challenged by truly independent bodies. So back to the English Revolution. When the monarchy was reinstated in the form of King Charles II, an act of free and general pardon, indemnity and oblivion was passed. This meant that deeds committed by the revolutionaries, except for signing the death warrant of Charles I, were forgiven but also forgotten. This seemed like a sensible act in terms of trying to restore peace and stopping retribution. But it also meant that most of the many good achievements of the revolution were also forgotten. One of those being a recognition that we did not need expensive bureaucracy, although that term had not yet been invented, to tell us what to do. As Franz Kafka has observed, the revolution evaporates and leaves behind only the slime of a new bureaucracy. I hope I have provided further evidence that the practice of medicine is not as rational as we might hope. Irrational and ineffective practices are condoned and even promoted by the medical establishment. The scientific journals and the professional societies are complicit. But in the UK, the malign impact of this is made worse by the state provider, the NHS, being in effect a monopoly. So remember, if anyone suggests a treatment for you, even if it is part of a national pathway, ask what the diagnosis is, how the intervention works, what the risks associated with the intervention are, and if there is any evidence of efficacy.